Hi everyone. So we've covered what menopause is, health effects, symptoms, natural remedies, but we do need to talk about HRT, don't we? There is no doubt that for many women, nothing works apart from HRT. Their symptoms are overwhelming, life is miserable. They're not sleeping, their brain isn't working, they're anxious, they don't feel themselves. For other women, they may have none of those things, no major or minor symptoms, but they worry about their bones, their heart and their brain. For women in both camps, HRT is appropriate if they want it. It's about choice. So let's break down the different ways of taking HRT. It will seem complex when you first hear it, but it isn't, I promise. So the first thing to know is that the way that you deliver HRT into the body differs if you've got a uterus or don't have one. So if you've had a hysterectomy, it's a little bit more straightforward, but as most people have not had a hysterectomy, I'll start on that basis and then explain the rest after. So for women who have their uterus, you do need to have two hormones as part of HRT. You need estradiol and progesterone. Estradiol is the hormone that is needed to solve symptoms, and progesterone is needed mainly to stop the lining of the womb building up. There are different ways of taking the hormones, and I'll start with the most risky, which isn't really that risky, to the least. So the first is a tablet. So a combined HRT tablet that you just have to take one of a day. You can take it sequentially, which mimics a menstrual cycle, just like the contraceptive pill. And you should have a period each month, but might not, but should. So this is good for women who have not reached that 12 months without a period mark. They're not actually defined as menopausal. If you are 12 months post your last period, you would likely have what we call continuous HRT. It's still just one tablet a day, but this time you have both hormones every single day and you shouldn't have a period. There is no danger in using either continuous or sequential at any point in your journey, but if you go for continuous too soon, you may have more erratic bleeding, which for some women is just pesky. Why would you want that? Many women like a tablet because it's easy, and that's fine, as long as the risks and the benefits are explained and understood. The tablet has two main risks. The first is breast cancer. Now this is because it contains progestin, and it's a small but present risk, around an extra 5 cases per 1,000 women over 5 years. Now to put that into perspective, if you drink a glass of wine a night, that figure would be 9, and if you're overweight, 23. So it's a very low risk. The second is a DVT or stroke. When you take estrogen orally, it's metabolized through the liver. This increases the risk of a blood clot or a stroke. The risk is very small, but it is there. So if you have any clotting issues or risk of clotting, oral HRT is not for you. The second way of taking HRT is transdermal. This means through the skin, and it refers firstly to the estradiol, and this method is known as body identical or bioidentical because the HRT is absorbed through the skin straight into the bloodstream and it bypasses the liver, so there is no risk of DVT or stroke. So let's look at the different ways of doing that. So you can have estrogen as a gel or a spray. You can rub it into the inner thighs or spray it onto the lower inner arms once a day. It's easy to apply. You shouldn't shower or swim for an hour, so many women apply theirs directly after their shower each day. Then you have to have progesterone to protect your uterus. The best way to do this is with a tablet called Utrogestan or micronized progesterone. And how you take this varies depending on where you are in your peri-menopause journey. So if you are perimenopausal, you have sequential, you take 200 milligrams at night for 12 days every month. And to make it easier for my patients, I tell them to take it from the 1st to the 12th of every month. Don't bother counting days. As long as you know that you take it every night for these 12 days, your uterus is covered and happy. Then if you want to take it continuously, so you're menopausal, you take 100 milligrams every night with no break, just like the estrogen. This keeps your uterine lining suppressed. The plus side of micronized progesterone is that the risk of breast cancer is really not present for the first 5 years of using it. The downside is that it isn't always brilliant at keeping bleeding at bay. Don't get me wrong, For many women, it works just fine, but when it doesn't, it can be pesky. It can also be difficult to tolerate, causing abdominal upset, pain, constipation. It can be used vaginally if it's bothering you, or even rectally to try and overcome these side effects. But this is an off-licence use, which doesn't mean it's wrong. It just doesn't have the required licence. And some GPs will be unwilling to use an off-licence medication. So I'm just warning you, but let me tell you, they can. There's nothing stopping them. There are alternatives to micronized progesterone if you don't get along with it, and the British Medical Society lists them. But believe it or not, my own GP refused to prescribe an alternative, even though I showed her this guidance. The alternatives are dydrogesterone, 10 milligrams for 10 to 14 days a month cyclically, or 5 milligrams a day for continuous combined. Medroxyprogesterone acetate, or MPA, 10 milligrams a day for 12 days a month cyclically, and a minimum of 2.5 milligrams a day for continuous combined. Or northistrone, 5 milligrams a day for 12 days a month, that's cyclical, or 0.5 to 1 milligram a day for continuous combined. It is important to remember that only micronized progesterone has no breast cancer risk for 5 years. If you choose one of the other methods I've just been through, the breast cancer risk, small as it is, does return. There is, of course, another way of having progesterone if none of these are working for you and you do want to continue your HRT. The Mirena coil. This is the coil with hormones, and it slowly gives off progestin and keeps the lining of the womb suppressed. It's licensed for 4 years in HRT, but it can actually stay in happily for 5. Mirena is a good option for perimenopausal women who do not want to get pregnant. HRT is not a contraceptive, and believe me, I have seen women get pregnant on it. So if pregnancy would be a disaster for you, you need to add another birth control to your HRT, and women can end up taking 2 lots of progesterone, which is not ideal as it's the PMS hormone. If they have the Mirena coil, pregnancy is covered off by the coil, but also HRT, so no further progestin is needed. Another bonus of the Mirena coil is that adjusting the estradiol dose can be done without worrying about adding more progestin. More of that later. Then another method is patches. Now this is the final method to consider. It's a patch. The patch contains both estradiol and progestin. They're easy, they're waterproof. Lots of women like them. They're see-through patches about that big, placed on the upper buttock and changed twice a week. I tell my women that they should choose 2 days a week, stick to them, say Monday and Thursday, Tuesday and Friday. Don't count days, that's a pain. Just change the patch on those days. Also, I always tell them to clean the skin thoroughly and make sure it's super dry before you put your patch on. Then they stick beautifully. In terms of risk, there's no DVT or stroke risk. There is still the same small risk of breast cancer. Patches come in both sequential and continuous. So, that's the lot, the different ways that you can have HRT. But it's important now to just add something for women who don't have a uterus. So you've had a hysterectomy and you don't need the progesterone, so you can have estrogen only as a tablet, a patch, a gel or a spray. With all of these, you have no risk of breast cancer. In fact, you have a reduced risk of breast cancer compared to the general population. With the estradiol tablets, you do have the DVT stroke risk, but not with the patches, the gels and the spray. So there is actually a net benefit of patches, gels, spray, estrogen only for women without a womb. And one last caveat to estrogen only for women without a womb. If you suffered from bad endometriosis, which may have been the reason you had a hysterectomy, it may be wise to still have progesterone to keep any rogue endometriosis cells at bay and to stop it being stimulated by unopposed estrogen. I think after all of this, it's important to say that some women choose their HRT type and sail off into the sunset, which is great and very rewarding, and we never see them again apart from a routine check. Some, however, find it takes a little longer and they need a GP who can and will tweak the treatment, do blood tests where needed. Now, I know I've said in other vlogs that over the age of 45, women shouldn't have blood tests, and I meant it for HRT diagnosis. This is different. Once treatment has started, it's sometimes necessary to check blood results to see if the estradiol is being absorbed, either enough or too much. There are women, I am one, who do not absorb estradiol through the skin very well. And you can put 6 pumps of gel or spray or 2 patches at a time and still have symptoms. At this point, I do an estradiol blood test. A good treatment level with that blood test is 300 to 650, and checking absorption helps me understand what is going on. Now, some women will have a level of 200 and all symptoms will be gone, and that's fine. The lowest dose required to treat symptoms is the best dose. But for others at that same level, symptoms will remain, and tweaks to dose or how you have the HRT in its form may need to change. So it's important to note that too much estradiol, generally over 1,000, will potentially cause exactly the same symptoms as not having enough. So this is another good reason to check levels. Sometimes a woman may need to move from a gel to patches or spray, and even to tablets if they don't really absorb well. But you'll only do that with a GP who's prepared to persevere, make tweaks, check bloods. Also, we used to think that progesterone didn't need increasing when we increase the estradiol dose, but now we do need to look at this and increase accordingly to avoid the uterus lining building up. In some circumstances, when high doses are needed, a Mirena coil then becomes a really good idea. Now, one last thing. If you're using a GLP-1 injection for weight loss, there may be some interference with progesterone. So the advice is to double the progesterone for 4 weeks every time the dose of the weight loss jab changes. Phew, so that's HRT. I know it sounds complex, but honestly, it's not really. Choose how you might like to have it, look at the risk profile, and if acceptable to you, off you go. If you want the lowest risk regardless, take the estrogen through the skin, patch, gel or spray, doesn't matter, and add micronized progesterone. I hope that helps. Take care, everybody. Thank you again for subscribing and for putting your faith in me.